Hello everyone, welcome to Twilight. Problem is possibility, and this is Dr. Rajalakshmi. Today I am going to discuss our second part of approach to multi-drug resistant bacteria. In previous talk I spoke about beta-lactamase producing gram-negative bacterial infection, and today I am going to talk about ESBL and carbapinamase or carbapinum resistant Enterobacteriaceae group. So first is ESBL, CTXM enzymes. These are the group of enzymes which will cause resistance to many beta-lactam antibiotics. The group of bacteria which have a high risk of having ESBL group of enzymes are E. coli, Klebsiella pneumonia, Klebsiella oxytoca, and Proteus mirabilis. If you don't have provision to check CTXM group of enzymes, we can use ceftriaxone resistance as a proxy indicator for ESBL. If ceftriaxone MIC is more than 2 mics per ml, we can consider it as that bacteria will produce ESBL and we have to avoid that group of antibiotics. So what are the preferred antibiotics when you detect ESBL producing bacteria? So first we need to decide upon what is the source of infection. If it is uncomplicated cystitis, you can use amoxicillin clavulinate, single dose of aminoglycosides, and oral phosphomycin. But problem with amoxiclav, especially in female patients, as there is vaginal flora, high chances of recurrent or treatment failures. And oral phosphomycin, reserve oral phosphomycin for only E. coli UTI, because in Klebsiella and other bacterial infection the phos-A gene will be there, so they will be inherent resistant to phosphomycin, high chances of treatment failures. So preferred antibiotic or first choice of antibiotic for uncomplicated cystitis caused by ESBL group of organism is nitrofurantoin and trimethoprim sulfamethoxazole. So if the source of infection is only urinary bladder, there is no involvement of upper urinary tract, prefer nitrofurantoin or trimethoprim sulfamethoxazole. If these two antibiotics are not tolerated or they are contraindicated because of other causes, you can prefer amoxiclav or single dose of aminoglycoside, especially amikacin. If bug is resistant to amikacin, you can use plazomicin if it is available. And reserve oral phosphomycin only for E. coli bacterial infections. Preserve fluoroquinolones and carbapinums. Don't use carbapinums and fluoroquinolones for first choice of antibiotic for uncomplicated cystitis. If it is complicated UTI like upper urinary tract involvement, pyelonephritis and all, in such scenario you have to give carbapinums, meropenem or ertapenem, imipenem cilastatin combination, or fluoroquinolones. You can use even trimethoprim sulfamethoxazole as a second choice. If bug is sensitive to some other antibiotics other than carbapinums, once you get culture sensitivity report, change over to other antibiotics, because to avoid evolution of carbapinum resistant. Avoid nitrofurantoin and oral phosphomycin because they will not achieve enough concentration in the renal parenchyma. There is no role of tetracyclines or doxycycline. If the source of infection is other than urinary tract, it's the only choice of antibiotics is carbapinums. Coming to carbapinum resistant Enterobacteriaceae or carbapinamase producing Enterobacteriaceae. The most common carbapinamases are Klebsiella pneumonia carbapinamase, which can be produced by any Enterobacterials. Even though the name is Klebsiella pneumonia carbapinamase, this enzyme can be produced by any other gram-negative bacteria. Other common carbapinamases are New Delhi metallo-beta-lactamases, Verona integron encoded metallo-beta-lactamase, imipenem hydrolysing metallo-beta-lactamase, oxycyclinase, AXA 48 like carbapinamase. So if we have provision, better to detect the type of carbapenem, because it will help us to take a decision or to tailor the choice of our antibiotic therapy. As usual, if source of infection is urinary bladder, that means if it is uncomplicated cystitis, you can use fluoroquinolone, ciprofloxacin or levofloxacin. Like external spectrum beta lactamase, you can use nitrofurantoin or trimethoprim sulfamethoxazole combination or single dose of aminoglycosides. It can be amikacin. If it is resistant to amikacin, you can use plazomicin. Avoid polymyxins as far as possible. If at all you don't have choice, give colistin, not the polymyxin B, because polymyxin B doesn't have urinary clearance. If all these first line antibiotics are resistant, you can use ceftazidime avibactam, meropenem veborbactam combination, imipenem cilastatin relebactam combination, and cefiderocol. But all these antibiotics you need to preserve for other complicated infections. As far as possible, try to manage with fluoroquinolones or nitrofurantoin bacteremia or single dose of aminoglycosides. If kidney toxicity or nephrotoxicity is not of your concern, especially if there is CKD already on maintenance hemodialysis, you can give single dose of aminoglycosides. As usual, phosphomycin is only for E. coli infections, not for any other bacterial infection. Oral phosphomycin associated with higher clinical failures than nitrofurantoin for uncomplicated cystitis. So as far as possible, avoid oral phosphomycin unless it is proven E. coli infection. Coming to complicated UTI, there is no other options. We have to go ahead with ceftazidime avibactam, meropenem, veborbactam combinations, imipenem cilastatin relebactam combination, or cefiderocol if available. If sensitive to meropenem and resistant to ertapenem, as per sensitivity report, if it is sensitive to meropenem, you can give extended infusion of meropenem if carbapenem testing is not available or if it is negative. But if carbapenem is positive, avoid meropenem as far as possible. But if extended infusion of meropenem, with the extended infusion of meropenem, if there is clinical improvement, continue with meropenem antibiotic therapy. Or if nephrotoxicity is acceptable in case of complicated UTI, you can give once daily dose of aminoglycoside. Other than UTI, same choice of antibiotic like complicated UTI. It can be ceftazidime avibactam or imipenem cilastatin relebactam combination, meropenem veborbactam or cefiderocol, or single daily dose of aminoglycoside. But better to avoid aminoglycoside. They may not achieve enough concentration in case of complicated sepsis. Unknown carbapenemase status, and patient has recently traveled to an area where metallo-beta-lactamase are endemic. So if there is suspicion of metallo-beta-lactamase producing a bacterial infection, you can combine azithromycin with ceftazidime avibactam or cefiderocol monotherapy, because if it is metallo-beta-lactamase, they may not respond to your ceftazidime avibactam alone. You have to combine avibactam with azithromycin or cefiderocol monotherapy. If it is intraabdominal infection, you can use high dose tizicycline or ervacycline as a monotherapy, or in combination with other antibiotics like polymyxins. Ceftazidime avibactam plus azithromycin or cefiderocol as a monotherapy, as I told in my previous slide, for New Delhi metalactamase or other metallo-beta-lactamase carbapenemase producing bacteria. Ceftazidime avibactam alone will not work. You have to combine azithromycin to ceftazidime avibactam. If it is OXA48 like producing carbapenem resistant enterobacterial infection, you can give ceftazidime avibactam. It is difficult to treat Pseudomanas. What is difficult to treat Pseudomanas? What is basically multi-drug resistant bacteria? If any of three group of antibiotics resistance has been demonstrated, like penicillin, cephalosporins, fluoroquinolones, aminoglycosides, and carbapenems. If any three of these group of antibiotics are resistant, then we can call them as MDR. What is difficult to treat Pseudomonas? It is resistant to all the following antibiotics: piperacillin tazobactam, ceftazidime, cefepime, azithromycin, meropenem, imipenem cilastatin, ciprofloxacin, and levofloxacin. Resistant to all these antibiotics, then we can call it as difficult to treat Pseudomonas. So how to treat it? You have to give ceftalozone tazobactam or ceftazidime avibactam, imipenem cilastatin relebactam, cefiderocol, or single dose of aminoglycosides. The choice of antibiotics almost similar to our carbapenem is producing bacterial infection, but ceftalozone tazobactam is additional antibiotic that we can use for difficult to treat Pseudomonas. So these are the five group of antibiotics which can work against difficult to treat Pseudomonas. In this, meropenem, vaborbactam is not there. Avibactam, relebactam expand activity of these agents mainly through the inhibition of AMP-C. So other complex resistant mechanisms it may not work against. So the treatment failures can be common, and cross resistance is also common. Ceftalozone tazobactam and ceftazidime avibactam, they share similar mechanism of action, so cross resistance between the agents can be observed. So these are the dosages of all the antibiotics that we use for all these extended drug resistant bugs. You can see them in our IDSA guidelines, but here I have collected all the dosages of all the antibiotics. Amikacin 15 mg per kg as a single dose if it is cystitis. Other than cystitis, 20 mg per kg, and as per kidney function you can decide upon the interval. Amoxiclav cystitis 875 mg BD. Cefiderocol 2 gram TID infused over 3 hours, each dose over 3 hours. Ceftazidime avibactam 2.5 gram TID infused over 3 hours, but it requires renal dose modification. Azithromycin 2 gram 8 hourly infused over 3 hours. The azithromycin should be given along with ceftazidime avibactam infusion, not as a separate infusion. Ceftalozone tazobactam, if it is cystitis 1.5 gram TID, other infections higher dose 3 grams TID over each dose over 3 hours infusion. Ciprofloxacin 400 mg TID or 750 mg BD. Colistin, ervacycline 1 mg per kg BD. Ertapenem 1 gram over 30 minutes, 1 gram OD. Phosphomycin 3 gram OD. Only one dose for cystitis. Gentamicin 5 mg per kg once or single dose. If it is other than cystitis, 7 mg per kg per dose. Subsequent doses as per pharmacokinetics. Imipenem cilastatin, it's only cystitis, 500 mg 6th hourly infused over 30 minutes. Other than cystitis, 500 mg 6th hourly infused over 3 hours. Imipenem cilastatin relebactam 1.25 grams 6th hourly infused over 30 minutes. Levofloxacin 750 mg OD. Meropenem 1 gram TID. Higher doses 2 gram TID over extended infusions. Meropenem vaborbactam 4 grams TID. Nitrofurantoin, if it is cystitis, 100 mg 12th hourly. Oral suspension 50 mg 6th hourly. Plazomicin, cystitis 50 mg per kg, single dose. Other infections subsequent 50 mg per kg and subsequent doses as per pharmacokinetic characteristics. Tigecycline 100 mg single dose, then 50 mg BD if it is uncomplicated intraabdominal infection. Higher doses, double the dose, 200 mg stat followed by 100 mg BD. Tobramycin cystitis 7 mg per kg single dose, or other infection 7 mg per kg per dose, and requires renal dose modification. Trimethoprim sulfamethoxazole, trimethoprim component 160 mg IV or per oral 12th hourly. 8 to 10 mg per kg trimethoprim component for other infections, divided 8 to 12th hourly, maximum 320 mg per oral 8th hourly. So these are the dosages of different antibiotics. So that's all. We will meet soon with even more interesting topic. Stay safe. Take care.